இங்க இருக்கா? Okay. Good afternoon, all. We welcome you all to the lockdown lecture series from Aravind Eye Hospital. So today, the lecture is by Dr. Koshy Zachariah. He completed his residency from the Aravind Eye Hospital and underwent training in Glasgow, followed by fellowships in surgical and medical retina in Glasgow and Newcastle. He specializes in cataract and vitreoretinal surgery and has innovated in the techniques of sutureless vitrectomy. We welcome you, sir, for our lecture on diabetic macular edema. Over to you, sir.
Good afternoon, everyone. We'll get started today. Can you hear me clearly? If you just raise your hands and let me know.
Yes, sir, we can hear you.
Switch on the thing and raise your hand.
Okay, I've just been told that it's not loud enough. I'll get a bit closer to the computer and we'll get started. So good afternoon, everybody. Thank you for joining the lockdown lecture series. My name is Zach Koshy. I'm a retinal consultant in Glasgow in Scotland. And I'd like to thank Dr. Venkatesh for getting me in for this, because it's really a pleasure to get back in touch with my alma mater, which is Aravind Eye Hospital, and I was there in Madurai between 1996 and 1999. Since then, I've been in a hospital in Glasgow, and it's interesting that there are not less than 5 of us from the same time, totally by coincidence, who work in the same department. Sai Leela is my batchmate from 1996, and she's married to Satish Srinivasan, who was a year senior to us. So my work is surrounded by people from Aravind, and we really enjoy our being together. But if that was not enough, I'm also married to Sonia Modi, who's from Aravind. So time at home is also not far from being in touch with Aravind. So it's a pleasure to be here today. And we are going to be talking about diabetic retinopathy, which is a very vast topic, but I hope to cover it in terms of how we got to what we are doing today, a bit of history, a bit of the pathophysiology of how the damage takes place and how it forms targets for our treatment, and as well as what is coming our way in terms of potential future lines of management. So when we look at epidemiology, it's a huge number of people who are affected with diabetes. It's 422 million today, but it's projected to be reaching around 650 million in 10 years' time. And with such a large number of diabetics in the world, we realize that after 10 years, around half of them would have developed retinopathy. So all of these patients would be there forming a bulk of our treatment population. After 20 years, almost all of type 1 and 60% of type 2 show some degree of retinopathy. And retinopathy is something that is to do with mileage. The longer you've had diabetes, the greater are the chances of you developing the problem. And right now, it is the largest cause of blindness in the working population, which is particularly important in terms of economic activity. If we look at how hyperglycemia causes a problem, glucose is used for energy. And if there's an excess amount of glucose which is not used for that, it then goes through 4 different pathways, which then mediate the damage that takes place. So primarily there is the diacylglycerol formation, which then activates the protein kinase C pathway. There is a sorbitol, which forms fructose, and that itself also activates the various changes that take place. Mitochondrial activation of superoxides through the hexosamine pathway, and advanced glycation end products. Now, what these are essentially glucose directly combining with amino acids in nucleic acids, lipids, and proteins, and changing the way they function. Now, all of these causes these 4 changes: oxidative stress, leukostasis, and inflammation, and they all are interrelated. Leukostasis occurs due to adhesion of leukocytes to adhesion molecules on the endothelium. And these then further mediate the release of various factors, primarily that of VEGF. And what all of these do is that they break the blood-retinal barrier, which primarily is given by the tight junctions between the endothelial cells and the pigment epithelium. And when these tight junctions are broken, it leads to leakage of plasma along with protein into the interstitial spaces. When protein accumulates in the interstitial spaces, there's an osmotic gradient which causes more fluid to come in, and this is what leads to retinal edema. The other thing that's changing is due to leukostasis and advanced glycation end products, there is also occlusion of the various microvasculature of the retina, which then leads to ischemia. And ischemia is a potent initiator of inflammatory agents and cytokines, which then further adds to the whole process and amplifies what we are seeing. And diabetes hits pretty much everything. The microangiopathy is closely related to the polyneuropathy because there is a feedback between neural tissue and vascular tissue. And this in turn causes cellular dysfunction. So it's quite a protein change in terms of damage that it causes. And then we see this as the clinical changes of ischemia and macular edema, classical signs that we look for. So when we do deal with diabetes, today we have multiple options. There is clearly the systemic changes that we need to try and control the underlying disease process, but there's also anti-VEGF, lasers, steroids, and surgery. How did we get here? If you look at the number of publications that have to do with diabetic retinopathy over the years, if you go back to 1940s, there were 10 publications. In the first decade of this century, between 2000 and 2010, there were just under 8,000 publications to do with diabetic retinopathy. And in these last 10 years, there were more than 37,000 publications to do with diabetic retinopathy. So it just gives you the idea of the amount of research that is taking place to target what is going to be an increasingly difficult public health issue. But we need to go back quite a few years, quite a few thousand years to see when it all started. So even the Ayurveda text, the Sushruta Samhita, written between the 5th and 6th century BCE, talks about a group of conditions which had a diuresis, so prameha or prameham. And they also noted that the urine was sweet, or madhumeha. So the initial signs of polyuria and glycosuria was noted as long ago as that. And this is not just to do with the Indian civilization, but it is also noted in the Chinese civilization and the Middle Kingdom of the Egyptian times. But a more modern terminology for diabetes came in the 2nd century from Alexandria, where Artes described diabino, which was the first use of the word, which led to the term diabetes, which is essentially passing through. So polydipsia, large intake of fluid, and polyuria, large expulsion of fluid. And it was quite natural to think that this was probably to do with a condition of the kidneys. But by the time of the mid-19th century, they realized it was pancreas, and there was also a correlation to glycosuria, fasting, and exercises. But also the important finding that vision loss, not related to cataract, was taking place in diabetics. But it wasn't until the invention of the ophthalmoscope that we actually were able to look into the back of the eye and now start seeing the findings that we recognize as changes from diabetes. And Edward Yeager was the first one to describe this closer to the turn of the century. And Nettleship from London describes edema again about the same. It was Julius Hirschberg who started describing stages of the disease, which we are now beginning to recognize as what we know of punctate retinitis, hemorrhagic form, infarctions of the retina, and diabetic glaucoma. Wilhelm Manz termed retinitis proliferans, again to do with proliferative diabetic retinopathy. So this is as far ago as 120 years that these were described. But it was Arthur James Valentine from the city that I work in who first described the histopathological changes in diabetes. And he noted that this affected the precapillary arterioles specifically. And there's something interesting about the precapillary arterioles. This is a part of the blood vessel structure which becomes bilaminar. So when you start from the heart, the aorta, it's a thick muscular structure with endothelium and a pericytic cover. But as you go towards the arterioles, which are primarily endothelial, the precapillary arterioles have only 2 layers, that of the pericytes and that of the endothelium. And this is critical in terms of how the pathology takes place. So we now know that hyperglycemia primarily affects the pericytes. So there's loss of pericytes. And the innate blood pressure within the blood vessels causes the endothelium to bulge out through these gaps of pericytic loss. And those are what we see as microaneurysms. As the endothelium bulges out, the junctions between the endothelial cells, the blood-brain barrier, is broken through the damage that we saw in the previous slides. And that then causes a release of plasma in the first instance. And plasma is nothing but water with protein and lipids mixed in it. The protein and lipids increase the osmotic potential, causes more fluid to go in. And this is what we primarily see as macular edema. Now, acute macular edema will see a thickening of the retina, but over a period of time, the endothelial pump, the pigment epithelial pump, will take the water away and leave behind the lipid and proteins that we see as exudates. As the degree of damage increases, blood cells now start flowing out into the interstitial space, which we see as hemorrhages. And these hemorrhages in the superior layers of the retina are flame-shaped, and in the deeper layers, they are more like block shapes. And when there is a block in the axoplasmic flow due to infarction, we see what we describe as cotton wool spots. Now, infarction leads to more VEGF release, and VEGF release then causes a vasodilatation of the blood vessels in a gross manner. But if you look at the veins, they are ensheathed in the retinal surface. So you can see the bulging of the blood vessels in between the points of ensheathment, which is what we call venous beading. And the next level of the VEGF process is actual formation of new blood vessels. And this IRMA, or intraretinal microvascular anomalies, is the first signs of a neovascular process taking place in the retina. But they are intraretinal, that means that they are still within the internal limiting membrane. It is when they break out through the internal limiting membrane into the vitreous cavity that we call them as frank new vessels and proliferative disease. And because VEGF is a soluble substance that is freely floating around, it can move into the anterior chamber, forming neovascularization of the iris as well as of the angle. So broadly speaking, there are two processes of pathology taking place. One is leakage, which we see as edema, but also occlusion and lack of blood supply to what are extremely hungry tissues, which are the photoreceptors and the other retinal elements, leading to infarction. And this then releases more VEGF, which then feeds into the cycle. So there wasn't much that was being done for diabetic retinopathy specifically. We knew that treatment for diabetes had already been established and trying to control the disease. But it wasn't until Zachariah had noticed a retinal burn in one of his students once he observed a solar eclipse that he realized that photocoagulation could be a means to address retinal conditions. So that technique was taken further and used to treat retinopathy. And at that time, there were two ways of doing that, using a xenon arc or using argon laser. But there were still lots of questions to be answered. The degree of treatment, when to start, how much to use, and where to target. And a lot was being done mostly by trial and error. But by the early 1970s, it was important for us to try and find out how best to tackle this. And this is when the landmark trials that form much of our treatment knowledge for diabetics came into being. So the diabetic retinopathy study, the ETDRS, the DCCT, and the DRVS. And all of these trials explain to us in a definitive evidence-based manner that not all retinopathy requires treatment, that the treatment itself comes with problems, and we need to have a balance between the damage that comes from the treatment itself and also from the disease. And there is a point of intervention when it makes sense to start the treatment. There was also the proof, the solid proof that control of systemic risk factors had a beneficial effect on retinopathy. And in terms of laser, it defined the indications. So it defined clinically significant macular edema, which was when we would apply laser in the macular region. It also spoke of panel photocoagulation and the timing to apply that for proliferative disease. And that then became the mainstay of our treatment for many decades, much of the second half of the last century and the early part of this century. And you can see that photocoagulation, this is being applied through an indirect ophthalmoscope for a PRP, was effective significantly in stopping severe visual loss in diabetes and has been the mainstay of preventing severe non-proliferative or proliferative disease from progressing to vision-threatening complications of traction retinal detachment, vitreous hemorrhages, and neovascular glaucoma. Then there is surgery. The DRVS, again, define when surgery would be useful. So you can see in this particular video, it is an eye that has had mature proliferative disease, it's had reasonably good laser, and yet there's a vitreous hemorrhage. And the most common cause of vitreous hemorrhage is traction of the vitreous on the fibrovascular proliferation remnants, which might not necessarily be active. So once the gel is removed and the traction elements are taken away, then there is nothing that is pulling at these abnormal blood vessels, reducing the risk of further bleeds. But there is the other problem of macular edema. Now, macular edema is something that can occur at any stage of the disease. It can occur even if there is proliferative disease or not. It can occur at an early part of the diabetic process, which might not be very obvious in other parts of the retina. And this critically affects your vision significantly. And therefore, diabetic macular edema is a problem that we have had to tackle. So initially, we had focal and grid laser photocoagulation. And the thinking was to try and reduce the degree of leakage, as well as try to increase the function of the pigment epithelial pump to try and get the balance of fluid in the interstitial layers to a better level. And one of the problems with focal and grid laser is that it doesn't lead to any improvement in vision. More, it aims to stabilize visual acuity. But that at least gave us something to hold on to for all the years till we had the onset of VEGF. Now, going back to 1956, George Weiss had postulated there was a factor X that was there in ischemic retina, which was responsible for neovascularization. And it was not till the 1980s that it was realized that this factor X is what we now know as the vascular endothelial growth factor family of agents. And around about the same time, there was also research going on in the use of anti-VEGF for colonic carcinoma, because there was the theory that tumor growth could be controlled by shutting down the to it. And it's noted that the vascular supply to tumor growth was of the neovascular nature, and that VEGF was a prime factor in allowing that growth. So anti-VEGF was developed primarily for that, but around about the same time in Bascom Palmer Institute, Philip Rosenfeld decided to use that for neovascular AMD. And that was found to be very effective. And then therefore we are now very familiar with the treatment of neovascular AMD with anti-VEGF agents. But it was really the use of anti-VEGF in the RISE and RIDE trials, ranibizumab specifically, which showed that it was effective in controlling leakage and the neovascular process in diabetic retinopathy. We now have the drcr.net, which has given a lot more definition to how we need to use anti-VEGF in diabetic eye disease. So Protocol I confirmed that ranibizumab with delayed laser, or laser followed by ranibizumab, or ranibizumab by itself, clearly the ranibizumab had a better effect than the other two arms. There was also the important question, very similar to what was asked in ETDRS and DRS, what is the right time to intervene? Because remember, these are injections into the eye. They too carry risk in terms of possible infection, not to mention the cost of the treatment. So protocol, we looked at when was the right time. If there is central retinal thickening and there is normal vision, is it useful to start anti-VEGF treatment? And protocol, we said that no, it is okay to leave increased central retinal thickness as long as the vision is normal. But if it starts dropping to 6/9, 6/12 levels, that is when you start considering initiating treatment. Protocol T looked at the three different agents that we have at this point of time, which is aflibercept, ranibizumab, and bevacizumab. And it showed that all three of them were equally good in achieving good control of central retinal thickness and stabilization of visual acuity. At visual acuities of 6/24 or better, they showed a clinically significant advantage of using aflibercept for severe diabetic macular edema with visual acuities worse than 6/24. Protocol S looked at anti-VEGF in comparison to laser as a non-inferiority trial for proliferative diabetic retinopathy, and it found that it was non-inferior. However, panel photocoagulation still remains the gold standard, A, because of its long-term effect, as well as the economical level of treatment. DRCR.net has got multiple other changes coming through various studies. There is of particular interest Protocol W, which looks at the effect of treatment in anticipation of severe visual loss. So effectively treating at the time of NPDR changes, non-proliferative changes, to see whether that could stop severe visual loss from diabetic macular edema or proliferative diabetic retinopathy. And another interesting part of DRCR.net is to do with photobiomodulation, that is exposing the retina to light and to see whether it has an impact on vision. And so this is Protocol E. There are a few others, but I've just mentioned these which are of interest in terms of current treatment as well as future treatment. The other important thing that has really changed the way we look at treatment of diabetic retinopathy is the use of OCT. So we now have swept source OCTs, which give us extreme clarity of the layers of the retina. And broadly speaking, if you divide the retina into the sensory layers of the outer retinal layers of the photoreceptors and the conduction layers of the bipolar cells and the ganglion cells, it allows you to think of what the function of the retina is and where the damage is taking place. And I've always found it useful to have landmarks in OCT. So there's the retinal pigment epithelium, which is the first landmark. And then there are the alternate dark layers and light layers of the nuclear and plexiform layers that go through. But specifically to OCT, in terms of prognosticating, we have now come up with the concept of disorganized retinal inner layers. So if you look at the top picture on your right, you will see that the left half shows that that typical dark and light patterns that we see are now become an amorphous, disorganized mass on the left. And this tends to carry a poorer prognosis for vision. The presence of intraretinal cysts in themselves are not problematic, but the size, the larger they are, the more likely to have a poorer prognosis. Subretinal fluid in itself is not bad because that tends to have a good response to anti-VEGF treatment. And the presence of an epiretinal membrane does tend to have a negative impact. Which then brings us to the potential for surgery in diabetic macular edema. As of now, there is no strong evidence to suggest that surgery is useful. This is me removing an internal limiting membrane in somebody with diabetic macular edema. And those of you who have experiences will know that the adhesion of the internal limiting membrane to the underlying retina is much stronger due to the fibrotic changes that have taken place in the inflammatory process of macular retinopathy. And also the fact that the ileum is quite fragile and brittle. So all of these changes, now the thinking here is that if you remove the ileum, you're removing the vitreous sump, which holds a lot of the protein molecules that mediate retinopathy. But while there might be improvement in the central retinal thickness, there is no clear indication that there's any improvement in visual acuity. Definitely in the 2-year data shows no particular benefit. But clearly, if you are doing a vitrectomy for proliferative disease to address fractional retinal detachment or frequent vitreous hemorrhages, or even just to be able to do a much better pan-retinal photocoagulation because of a hemorrhage preventing you from doing that, it's worthwhile considering addressing the macula as well at the same time. So in terms of what is happening looking ahead, there are more than 400 active trials dealing with various means and modalities of addressing diabetic retinopathy. And these are to do with drugs with increased penetration. So most of the, in fact, all the drugs that we have now need to be injected into the eye. What if they're able to come up with a molecule that can actually penetrate the cornea, enter the ocular cavity, and therefore have its effect without requiring injections, or increased affinity to the various receptors in the ischemic retina, and also increased stability of the actual molecule. And all of these, as you can see, is aiming to increase the longevity of action. And there are alternative targets. Of course, there is VEGF, and there are new molecules coming out to deal with that, but there's also trying to increase the stability of the blood-retinal barrier, or reduce the permeability, counter the inflammatory process, and reduce leukostasis. And then, of course, there's alternate delivery pathways, not just through injections. So we'll just look at a few of them, because while there are these 400 trials, if you look at their current status, a lot of them have fallen by the side. And this is the reality of modern pharmacological research and development, that you might start with 1,000 trials, but you might just come up with 1 or 2 that are actually effective, and we can move forward into stage 3 human trials. So if you look at anti-VEGF, there is the designed ankyrin repeating proteins. And this is just a new molecule that has a capacity to combine with the VEGF receptors, and Epidemiology has moved to stage 3 trials. There's brolucizumab, which is also in stage 3, and there's Convercept. So all of these 3 molecules are different to what we are currently using in terms of anti-VEGF, and therefore they can combine potentially with the current molecule that we have to try and increase of effect, and therefore reduce the frequency of injections. Alternative targets, one of the prime molecules is the Tie2 pathway. Now, the Tie2 pathway aims to preserve the membrane stability, or the tight junctions between the endothelial cells. So activation of the Tie2 pathway improves membrane stability, reduces leakage. And there is a molecule being developed by RPO laboratories in Germany that is looking at trying to directly activate the Tie2 pathway. The interesting thing about the Tie2 pathway is that angiotensin 1 promotes the Tie2 pathway, and angiotensin 2 counters the Tie2 pathway. So if you have an angiotensin 2 blocking agent, it allows angiotensin 1 to continue to stimulate to the Tie2 pathway. So faricimab is a drug which aims to counter angiotensin 2 within the retinal tissue. And then there are other molecules which are looking at the various cytokines which are part of the pathological process causing the blood-retinal barrier to break. And so anti-cytokine activity can break the cascade that takes place, leading to leakage and occlusion. And then there is photobiomodulation, which I told you, DRCR AE protocol is looking at it. And there is some interesting results coming out from that, but it is still not completed. When we look at the actual drug delivery, right now we're using injectable drugs, but there's also the possibility of using ports that are placed in the pars plana, and therefore you can refill these ports, or micro pumps which act in a similar manner, or encapsulated cell technology, which again puts the drug within the vitreous cavity, but doesn't release all of it at the same time. So the encapsulated cell degrades over a period of time, releasing more and more of the drug as time goes on. So you can see that there's a wide range of research going on to try and target the various molecules that are part of the process that we now understand so much better over a period of all these years of research. So where do we stand today? Yes, there are the anti-VEGF drugs there is laser. But both of these, the question was asked, what is the right time to treat? And how long should we treat? And how far should we treat? It is now well established that if we give anti-VEGF injections, and after, let's say, 3 or 4 injections, we have achieved stability in the central retinal thickness, as well as visual acuity, then that is what we should establish, because beyond a point, we will not get the improvement that we are looking for. So once we achieve stability, so let's say that there was improvement over the first, second, third injection, but after the 4th and 5th injection, we have seen that the central retinal thickness remains much the same and the visual acuity remains the same, then that is our target. That is our benchmark for further treatment. In terms of sustainability, the role of laser is still very much there. Even in my own practice, every once in a while, I would use macular laser as an adjunct to anti-VEGF treatment to reduce the overall need for anti-VEGF injections. Because those of us who have seen endophthalmitis in a post-injection patient know the absolute risk that we expose the patient each time we inject a drug inside the eye. The other thing, of course, that we have to maintain is screening. In Scotland, we have a very good diabetic retinopathy screening service, which looks at all diabetics who are registered, and they're screened every 6 months or sooner or later, depending on their disease level, and then they are pushed up to treatment if necessary. We also got to bear in mind that the patients themselves have to be educated on the importance of systemic control, because rampant diabetes, uncontrolled diabetes, is the fuel to the fire. If you control the diabetes, you shut the fuel and the fire settles down, because what we do in terms of treatment is only firefighting. We are not actually making things better. We're only stopping things from becoming worse. So the ultimate control is finally down in their hands in terms of controlling things. And what about the future? Well, there's a lot happening in terms of artificial intelligence. We spoke about how there are so many trials going on. Now, trial molecules are put through artificial intelligence algorithms to see which might likely be beneficial, which might likely be useful as a mode of treatment. Because remember, developing and conducting a trial is a very expensive process. So there's no point doing 1,000 trials and finding only 2 of them work. If artificial intelligence algorithms can do all of that work before, then that is one way of reducing the time from theory to actual practice. Then there is gene therapy, which might help with changing the way certain proteins are manifested, which can either benefit the membrane stability or actually degrade the process of pathology that is taking place. So that hopefully is a coverage. I think I've spoken for around 40 minutes, and I'll break now and open up for questions. But before I do that, like I told you, we have a number of people from Arvind in my department, and if any of you would like to spend some time with us, please email me. I'll be very happy to arrange for that. Thank you.
Thank you very much, sir, for this wonderful lecture. We are now open to questions. If you want to ask questions, you can just unmute your mic and directly ask the questions to Dr. Koshy.
Are there any questions that you might like answers to?
Hello, am I audible?
Yes, please go ahead.
I
Hello?
just would like to know Hello?
Hello, yes, please go ahead.
I would like to know what are the minimum number of injections you go ahead and give over there before you can actually say, you mentioned in your talk 5 to 6. It is not that every patient would be the same 5 to 6. So is there any target CMT that you look at, or how do you go about saying it's 5 to 6?
I was using 5 to 6 as an example.
Yeah.
Now
Could you elaborate on that?
Yes, I will. Now, most of the trials started off with a loading dose of 3 injections 1 month apart. Now, more recently, we are actually moving away from that as well, in the sense that, do we really need to give them a loading dose of 3 injections 1 month apart? Can we give them 1 injection, a second injection, and if on the second injection we've seen that there's no further improvement in central retinal thickness or visual acuity, then can we start extending the interval between their treatment? So trying to answer your question, it is ultimately to try and achieve that plateau. So as long as there is a continued gain in visual acuity, then it makes sense to continue injecting. But most people will achieve that stability within the first 3 to 4 injections.
Okay, thank you so much. Am I allowed another question?
Yes, please. Go ahead. Hello. Sorry, was there one more question from yourself?
Hello. Hello.
Hello, yes.
Can you hear me?
Yes, I can.
I'm Dr. BNR Subudhi from Odisha. I would like to ask a question. So whether you will go for anti-VEGF injection directly or you will do the laser and go for the anti-VEGF? The role of PRP.
So if you're talking about proliferative disease,
Yeah.
I'm very clear that, at least in my practice, in my setting, that I would go for a panretinal photocoagulation. I still reserve anti-VEGF injections for macular. However, even in patients who have had PRP, who have had a vitrectomy for recurrent vitreous hemorrhages, sometimes we find that giving them 1 or 2 anti-VEGF injections helps to control the recurrent bleeds in patients who have had surgery and who have had panretinal photocoagulation. So anti-VEGF injections I would use in those circumstances.
Right. Would you prefer Avastin or ranibizumab or aflibercept? Which one you prefer?
I would prefer Avastin, but in the United Kingdom, we are not allowed to use Avastin yet because it's not a licensed drug.
Right.
I feel that it functions as well, and definitely as a cost-benefit analysis, there are a number of studies which have proven that it is it's a viable option.
Right. Thank you.
Hello.
Yes.
Sir, do you consider a pre-op injection Avastin before a vitrectomy just to prevent the bleeding or anything? Does that practice happens in UK, or what's your
It
opinion?
does. It does. There are pros and cons to it. The pros, of course, is it makes life a lot easier for the surgeon. When you give an injection of anti-VEGF 2 days before or 3 days before a vitrectomy, the degree of time that you spend inside the eye trying to control bleeds and all that is a lot less. But it is absolutely important that you follow up the injection within days.
Yes.
Within days of, otherwise, the tractional changes
will
can
improve.
cause more problems.
Okay.
The other downside is that suppose it's somebody whom you've not applied laser to in the past. So if somebody who's come with a fresh vitreous hemorrhage, there is neovascular changes, you have no access, and therefore you're going to do a panatal photocoagulation as well. The anti-VEGF can actually mask the actual state of the retinopathy. So you would apply laser thinking, oh, this is not a huge amount of retinopathy, I'll just apply maybe 1,500 burns. That is a false impression that you have because of the anti-VEGF effect. So you should be prepared to apply more laser if necessary after the surgery. And this is also one of the reasons why we get recurrent bleeds after a vitrectomy, because the anti-VEGF has actually made you or tricked you into under-treating the retinopathy with PRP.
Okay. So within days itself, the VEGF will act, and you will have the changes in the retina when you go.
Yes. After 24 hours, the effect is seen.
So, sir, how long do you wait if the patient is having a recurrent vitreous hemorrhage post vitrectomy, just other than before vitrectomy, we wait for things whether it's a settle down, and then you go ahead with decide with vitrectomy. So, like if a post vitrectomized eye is with the recurrent vitreous hemorrhage, so like generally how long should if you see the patient for the first time? The patient was done vitrectomy elsewhere and come back with a vitreous hemorrhage to us.
It depends on what treatment the patient has had so far. So, for example, if somebody who's presented to you with a fresh vitreous hemorrhage and they've not had laser before, that is an unstable eye.
Okay.
And therefore, there is a degree of urgency of going into the eye to try and clear the blood so that it can stabilize the pathology. Once you have done a vitrectomy and there is recurrent vitreous hemorrhages, that is not such a worry, because the vitreous is removed, the blood will clear up on its own. And most of these hemorrhages will clear up without you having to intervene again. The one thing that you should look out for, of course, is a gosser glaucoma. And therefore, that would then become a definite indication to go in for a vitreous washout. But otherwise, our urgency for treatment once a vitrectomy has taken place is a lot less compared to somebody who's not had treatment before.
Okay. Thanks a lot. A wonderful class.
One question, sir.
Please.
Hello.
Yeah.
Treatment unresponsive diabetic macular edema, either due to resistance to anti-VEGF or laser. What will you prefer first? Would you prefer a steroid implants or directly vitrectomy with ILM peeling?
That's a really good question, because my practice has changed over the years. As surgeons, we like to be aggressive, I think. So we used to go for a vitrectomy in these patients. And there was also this underlying thinking that, are we doing the surgery and the ILM peel too late? And that's why we're not seeing much improvement. What if we had gone in sooner? Would it have had a better effect? But there are clearly enough studies out there which say that doing a vitrectomy for recalcitrant macular disease is not necessarily beneficial. But there are certain pointers which would then say, yeah, if I did that would be useful. One is an epiretinal membrane. The second is the presence of vitreomacular traction or broad-based adhesion. These would then become targets for surgery which you can attack. In terms of the other modality for recalcitrant edema, now, once you've tried anti-VEGF, you can switch the agent. There is some benefit there, which might or might not take place. So if you are on ranibizumab, you switch to aflibercept or vice versa. I'm talking about the practice in the United Kingdom. And then there's also the option of adding a steroid to that. So after 6 months, for example, if you haven't seen any improvement, then you should consider a steroid as an option. But I think the basic underlying issue in all of these cases is that if you have not seen an improvement after the first few injections, it's likely that the disease process itself has gone beyond the capacity of all of these treatments.
Yes.
Traction, of course, is definitely part of the equation. And if you can attack traction, definitely doing a vitrectomy makes logical sense. But otherwise, it might well be that the pathology itself has gone past our capacity to do anything beneficial.
Yes. Understood.
Saying, you don't flog a dead horse, so there's no point injecting
Sure.
a retina that's not
Yes.
well.
Thank you.
Sir, in addition, there are a few questions in YouTube channel. So one of them asked if the patient has got a proliferative diabetic retinopathy, and would you prefer anti-VEGF or just PRP? And if you're doing only PRP, would you be more aggressive and do a very closely spaced burns, or the burns as one width apart, one burn width apart?
I'm probably a bit old school in that way because I have seen the beneficial effect of PRP in a number of cases. And so I would still go with PRP first. I definitely feel that multiple injections is something that is still a luxury for proliferative disease because there's no endpoint till such time the balance is readjusted in terms of perfusion and demand. And that demand is always going to be there till such time that the diseased retina or hungry retina is killed off, which is what a panel of photocoagulation does. In terms of the actual degree of laser that I apply, that I tend to modulate based on two things. One is if we can get a wide field angiography, you can then go for targeted areas of ischemia. Now, if you do not have wide field angiography, you are still able to get some idea of where the fields of ischemia are by just looking at the other signs of where the ERMAs are, where the new vessels are, and where the infarcts are. Often ERMA and new vessels occurs at the junction between ischemic retina and non-ischemic retina. So peripheral to ERMAs is an area that I would target with laser. In terms of burns, we now use a Pascal, so that's I keep it at one burn width apart. The degree of laser apply is titrated, so I normally start with a level which I think is representative of the degree of retinopathy, and then add more burns depending on the response. And I normally wait for around 6 to 8 weeks between applications to see whether I've achieved what I want. So the first application is full on to what I think is the level of disease that requires it. And that can vary from 1,000 burns up to 2,500 burns. But thereafter, anything additional, I'd give it around 6 to 8 weeks to see what the response is before deciding whether I need to do anything beyond it.
And when there's the earliest appearance of NVI, so do you inject in those patients or just PRP and wait?
There are situations where we inject first because either we don't have a view to the fundus, in which case we give the injection first off, and by that time to be able to apply the laser. And also in situations where the NVI is quite mature and it's quite florid, then I feel that giving the injection first, putting a stop to it, and then allowing the laser to build up into its effectiveness is useful. But I don't do that always.
And there's another question by Dr. Saran, who is asking if the patient has got a vision of 6/9 and a TRD, do you still operate on that patient?
I'm sorry, a vision of 6/9 and what?
Traction retinal detachment.
Yeah. Again, it is to do with perception of threat. You can have somebody with 6/6 vision and a traction retinal detachment involving the arcades, which threatens the macula and the 6/6 vision. So if the vision is good, but the threat of the traction retinal detachment to the macula is active, then I would go for it.
Is there any cutoff value of the central macular thickness where we choose between laser and injections?
No, not in my practice, because ultimately both of those modalities, injection and laser, is targeting the pathology through different pathways. And ultimately, the decision that you will have to make is not necessarily on central retinal thickness, but more in terms of how much your patient is going to be able to keep up with the line of management that you choose. So, for example, there are situations where we have patients with multiple diabetic related pathologies, meaning that they have to go to a number of clinics, they're on dialysis and all of these things, which makes their capacity to attend our clinics on a regular basis difficult. In such situations, or younger people who are not who are in the working age group, who are not able to keep their appointments, in such situations we have that conversation with the patient and say, look, we will go with something that gives you a longer duration of effect, though not necessarily giving you the improvement that we're looking for. So sometimes it's a combination. We give them an injection, a bit of laser, and hope that that works till such time. It also gives them the chance to control their underlying diabetes, because now you've had the conversation with them, you told them how much their vision is at risk, and that at their age going blind is not something that they should take lightly. And hopefully that then feeds into their diabetic control and gives you a much longer term benefit. So injections, yes. Lasers, yes. Combinations, yes. But it all really depends on the person you're treating.
Hi, Dr. Koshy. I'm Dr. Ayushi. I have two questions for you.
Yes.
Am I audible?
Yes, you are. Thank you.
Yeah. So the first scenario is that, I want to know how aggressively do you treat these patients with DME who have 6/6, 6/9 vision with a small foveal cyst, because sometimes the response to treatment, it really doesn't come with 2-3 injections. So what are you doing in these patients? I mean, how do you manage them and how aggressively do you manage them?
So I tend not to treat them. These are the people that I would observe closely.
Okay.
Tell them what the threat is, and hopefully that you've caught the disease process at a stage where it can still have some impact on the progression. But no, if the vision is good and 6/6, 6/9,
and they don't have metamorphopsia, I think even we do observe. So
yeah, so I would observe rather than treat. And
Oh,
that has now, that used to be my practice all along, but
yes.
the DRCR protocol now support that.
Okay, all right. And the second question is, like, I had a patient recently. So the other eye, the bad eye was lost to NVG, and the good eye had around 636 vision. It was a lasered PDR and dense cataract, NS4, and the patient came with MBI, and it was not in the NVG stage, but patient had undergone an open heart surgery a month back. So, we were in a fix, whether we go in for an anti-VEGF, laser was not possible. There was dense cataract. So how would you manage such a case? One night patient, recent bypass surgery done. So this was challenging for us.
Yeah, in that, my treatment algorithm would be to keep the anti-VEGF away as far as possible. So
Yes.
I would go with getting the cataract out. I don't think there is a huge disadvantage to operating the immediate aftermath of his cardiac procedure
Yes.
of getting the cataract out. The difficulty, of course, is that just doing the cataract in such a labile diabetic retina would almost definitely cause macular edema. So
Yes.
I might even combine doing the cataract surgery with some kind of steroid injection, whether it's
Okay.
triamcinolone or Norzadex, possibly triamcinolone in the first instance. And
Okay.
then you would very quickly have the capacity to view the posterior segment and
Right.
see what should be the next level of laser treatment that you can apply. In the meantime, the steroid injection has also bought you time and stability of the macula for whatever treatment that you're going to plan thereafter.
All right. All right. Would you think of ARC in this case? Like suppose if we have a little bit of view of the retina, maybe but I don't think that will really help, because I think a good laser would be better for such eyes. But would you think of ARC in such a case?
No,
You consider
because I don't see the disadvantage. I mean, others can chip in here, but I don't see the disadvantage of doing a cataract surgery, which is something that you're going to have to do anyways. So
All
why
right.
not do it now and cut to the chase and do what it takes?
All right. All right. My only concern was, when I was treating this patient, if I go in for a cataract surgery, is that going to worsen the NVI and the anterior segment neovascularization? So that's where the doubts were coming in my mind. Yeah.
So,
Okay.
absolutely. That surgery is not going to be easy.
Right.
Your pupil is not going to dilate very well.
Right.
Your capacity to use pupil expanders, if that's what you need to, is not very good in an eye with NVI. You're going to cause more inflammation, more damage, and therefore, it the more you think about it, the more you say, yes, I would have to do the surgery with a parallel steroid injection.
All right. All right. All right. Great. Thank you. Thank you.
Any more questions?
I think we have few questions from our YouTube channel. So Dr. Sachin is asking whether you combine cataract surgery with anti-VEGF IVT in diabetic eyes with DME.
Yes, we do. We do for similar reasons discussed in the previous question, that it gives a protective effect of the progression of retinopathy that occurs after cataract surgery. It's the same thing. It's a sensitive retina. It's already been primed for inflammatory changes. And what cataract surgery does is it amplifies that process. So if you can do something at the same time, be it an anti-VEGF injection or a steroid injection at the same time, then you are protecting that process from getting worse.
Right. There's another question here where I think Dr. Sachin again, he's asking during PPV, in which cases do you prefer ILM peeling? Even I have this question because a lot of these TRDs and the FPPs that we do, and you don't always peel the ILM. And you do see that, there is skytic, which is left behind. Even under oil, you see that these, that remaining vitreous does organize and again starts causing attraction over the macula. So when do you really advise ILM? Even if there is no TPH, do you still advise ILM peeling?
So I learned this lesson the hard way.
Yes.
Like, many years ago, I would just do what was required in terms of the tractional changes and the proliferative changes and come away. If the macula looked fine, I said, don't mess with it. But like you pointed out, invariably you see that there are changes of, in any eye that you do a PRP, there is going to be fibroblastic activity. There's a high correlation between PRP and epiretinal membranes in diabetics.
Right.
So now my practice is that if I'm going inside the eye of a diabetic, I will do an ILM peel. And that's primarily to safeguard against future epiretinal membrane proliferation, because When you remove the ileum, you're removing the scaffold for the fibroblastic growth. And
Correct,
therefore,
correct.
you reduce the risk of that from happening. So I learned that the hard way. I'm not sure if there's any trial-based evidence there to suggest this as standard practice, but that's what I
there
did.
isn't. Yes, yes. I think I was also, I think I'm also in the hard way of learning, but I also realize that few of my patients are getting a pucker. And I think we have to be a little bit more patient and maybe just do a peel and all the TRDs and FPPs. I think that'll be better.
The reason, I mean, it's not about patience, it's about the damage that we can potentially do.
Okay,
You
okay.
would notice that everything that we do extra
Right.
comes with a risk.
Definitely.
So when you're doing surgery, you just want to do as much as is necessary so
True.
that you come away without taking any additional risks. So when you do an ileum peel, particularly in a diabetic where the ileum is so adherent and so friable, there is always a slightly higher risk of causing iatrogenic trauma.
Yes.
But you take that risk knowing that if you don't do that particular step, you have seen from your experience that it ends up causing problems further down the line. So that makes it, in my book at least, a worthwhile addition to what you're planning for your surgery.
Yes, yes. Agreed, agreed. All right. Thanks a lot, Dr. Koshy. Thank you.
So if there's no more questions, we'll bring the session to a close. Thank you all for your interest and good luck.
Thank you, sir.
Thank you very much.
Thank you. Bye-bye.